The original laryngeal mask airways were introduced over 2 decades ago as a safe, effective alternative to the endotracheal tube and the face mask. Clinicians around the world choose to use these airways millions of times a year. Over 2,500 publications and hundreds of clinical studies have tested and provided a wide variety of uses for these airways. The LMA has become the most respected supraglottic airway device worldwide. LMA airways are available in a complete range of both reusable and single-use versions. While the reusable LMA remains a popular and cost-effective choice, the single-use LMA airway have the same benefit, but with the added convenience of being sterile packaged and fully disposable. This CBO is to be performed in the simulated clinical setting. All materials herein are meant to prepare you for this CBO. You have just seen the indications, contraindications, and the side effects associated with the use of the laryngeal mask airway. The next couple slides will take you through the steps for preparation of the LMA for insertion. You should be prepared in the laboratory to review all of these materials for your evaluator prior to and during the evaluation session. Make sure that you have the equipment prepared, that you're able to talk about the various sizes of the LMAs, go through techniques of examining the LMA, deflation and inflation of the LMA, including the appropriate size syringe, as well as the use of lubrication of the LMA and the type of lubricant that is commonly used in the operating theater. Ensure that positioning of the airway is done according to proper technique. A short video from intersurgical.com will now review all these aspects.
What we're about to demonstrate is the correct insertion technique for the intersurgical solus laryngeal mask airway. Firstly, it is important that you select the correct size for each patient, and the patient weight does appear on the airway tube. Next, prepare the laryngeal mask airway by fully deflating it to a very tight vacuum. Contrary to some popular belief that there should be some air in the cuff, this is not so because a filled cuff can collide with the epiglottis. Next, prepare the solus for insertion by putting some gel or lubricant on the back of the cuff. Just on the tip of the backplate is all that is required. Then, in readiness for the correct insertion technique, insert your index finger into the slot formed behind the flattened cuff and the junction with the airway tube. Then prepare the patient by tilting the head back and bring the tip of the laryngeal mask airway laterally towards the patient, not downwards, but resting the tip behind the teeth and gums, because you're going to utilize first the hard and then the soft palate of the patient to perform a sweeping action that optimizes the anatomy as an introducer tool. Inserting the laryngeal mask vertically or obliquely brings about difficulties, but by following the curve created by the palate, rather than bouncing off the back of the throat, is by far the simplest method of effective insertion. So we are ready now to start inserting the laryngeal mask airway. And there you see it, following the natural curvature, with the finger going as far as it can, and then using the other hand to stabilize the laryngeal mask as you remove the introducing finger. Then with a pre-prepared syringe, inflate the correct volume. You will notice that not only is the cuff inflating in the pharyngeal cavity, but the connector is also rising slightly, which is an indicator that the laryngeal mask has been fully inserted. The tip of the cuff is now sitting over the esophagus, which is acting as a form of partial stopper, either against reflux coming up or possible minor leakage of gases into the stomach. The epiglottis is resting over the top of the cuff, and the whole of that section is now completely filling the pharynx, which is a special feature of the laryngeal mask airway, because now the nitrous oxide or other gases are being directed solely through the trachea and into the lungs.
Lastly, you should be prepared to talk about the use of the LMA with a mechanical ventilator in the OR. Considerations may be short-term, making sure that airway pressures are kept low to limit the opening of the esophageal opening pressure, which occurs approximately 20 to 25 centimeters of water. Patients should be fully monitored and only provided by experienced caregivers. This is not a definitive airway. Use aseptic technique throughout the procedure. Wash hands at a sink. or with an approved alcohol-based product. And don gloves for all aspects of the procedure at the patient's bedside. Identify the patient, yourself, the department that you represent, and your role as a respiratory therapy student at NBCC SJ. By following through on the various steps identified on this CBO video, as well as with specific review of the information that you've received, both from your notes and within your clinical practice, we're more than confident that you'll be able to challenge the CBO and successfully prove the insertion of the laryngeal mask airway. Thanks for listening.